When you think about medical family therapy, what I hope that people are able to kind of bring to mind is thinking about healthcare through their physical well-being, their emotional well-being, their relationships, their spiritual health. That approach is called the biopsychosocial spiritual approach, but we live it every day. We don't want people to think about their health in silos, that you go to a medical context for your physical pains or your illnesses, and that you have to go somewhere else for your mental health care. That bridge needs to occur in everyone's life so that they're seen as a whole person, that every part of them is cared for. And that needs to take place not only in relation to healthcare and clinical services, but we need to think differently about the research that we're doing, the policies that we're making, so that everything from ground zero clear up to the government, that change is seen holistically.
So I interned in probably 6 different departments across the hospital, and those relationships were already cultivated. So I was able to get experience in internal medicine, in family medicine, in psychiatry, in OBGYN, and to be welcomed there and learn about the medical system, that was huge. Because after I left ECU, I found out how rare it is that the marriage and family therapy is so integrated into the medical school and residency program.
In my current role, I'm not only a faculty member, but also serve as the clinic director of our outpatient clinic. And so I think the program allowed me to have a keen understanding of systems of care, about all the moving parts of a system, not only within a family, but within a healthcare system, and the need to take care of our healthcare workers, whether they be staff or physicians or nurses, and how to navigate that process and be a leader as our system of care moves forward.
It sounded really exciting to us to try deploying this integrated care model, and people weren't doing this. People were doing this in limited ways, primarily with depression or other disease entities, where the providers would either co-locate or have other close arrangements, but weren't truly integrated right into the same practice completely. And we decided that we wanted to be one of the first people to try that through Greene County Healthcare, and we did. And it has been a marvelous partnership. We have had a very, very close relationship, enjoyed a very close and positive relationship with Drs. Lamson and Hodgson, our dear friends now, and their students and their graduate students. And of course, this was the first doctoral level such program in the United States, and has produced some really quite extraordinary graduates, and I know most of them. It's really wonderful, and see them now in their own careers and carrying this model elsewhere, and have been very appreciative of their quality of their research as well. These patients actually always know the therapist by name because I call him or her in at the time of the visit, or that person goes in advance of the visit and greets the patient and checks out the situation and comes in and reports things are better. We believe that we are an exemplary model of truly integrated primary care. We believe that we are serving a population whom we can uniquely serve, a population whose biopsychosocial milieu is highly complex and which is intimately interactive with their disease processes. How in the world can you expect a woman who can barely put food on the table to maintain her hemoglobin A1C level at below 7, as we try to get them to be? And that A1C is an indicator of diabetes control, long-term indicator of diabetes control. How in the world are you going to do it? How you going to do it when she's working 2 jobs and you're going to help her figure out how to do it? That's an example of something. How do you help a mother deal with a child who has terrible rage because of things he was exposed to in his early life that his mother hurts about so much that she can't talk about them? And how do you help her figure out what to do? How do you help her learn to communicate about it? And you do it in partnership so that there's completely seamless connection between the medical provider, the member of the nursing staff, the patient, and the therapist. We're all there together. We're all a team. So I do think we're really on to something. We happen to practice in a fully integrated care model, but this is a unique group of people who are trained to practice family therapy or so-called marriage and family therapy in the primary care medical environment. And it works. It works incredibly well. My patients love it, and I love it. It's a real struggle to produce the kind of data that will convince everybody of how well it works. But I can tell you this, I've not had a bad experience. Every experience that I've had with a problem patient with whom I've been partnering, in whose case I've been partnering with MFT, has been a positive outcome for me and for the patient. There hasn't been one that hasn't. And there's never been a case where I believe that the MFT person involved did not make the outcome better than it would have been if he or she had not been there.
We actually think we can make a difference and make things better for people, and that's what we do.